Hello, everyone, and welcome to another episode of Fertility Docs Uncensored. I am one of your hosts, Dr. Carrie Bedient from the Fertility Center of Las Vegas, and I am joined by my two fantabulous co-hosts, Dr. Abby Eblen from Nashville Fertility Center
Hey, everybody.
and Dr. Susan Hudson from Texas Fertility Center.
Hello,
How
hello.
are you, how are you girls doing this morning?
Doing good.
I've been helping my family move.
Oh,
That sounds
you
like a
must like your
blast.
family.
Yeah, I was going to say.
Yeah, it actually hasn't been that bad. We've had lots of assembly lines of passing boxes.
Oh, wow. That sounds like you're organized.
On the trailer, which was very satisfying.
So, did you guys see the email? And I'm asking this because I obviously know the answer well ahead of time. But did you
Drum
guys
roll,
see
drum roll.
did you guys see the email about notifications of numbers of our episodes?
We made
Yes,
it.
a million.
We made 1 million downloads.
So
Um,
thank you to all of our listeners who listen and download. That is a huge milestone for us, and we are so thankful. We couldn't have done it without each and every one of you.
Yeah, I had no idea that us just chatting would really draw that many people. Thought we'd be somewhere like in the podcast junk pile somewhere by this point, 4 years later, four
uh-huh.
and a half years later.
Uh-huh. We are super appreciative and just the ability to know that we're able to impact this many people because there's downloads which registers, but that doesn't register, it just listens. And
Mm-hmm.
so it's probably 2 to 3 times that much, at least of people who down or who listen to it but don't actually download it. And to know as a physician that we can help that many people is just phenomenal and makes all those years of really kind of nasty training
Yes,
come
sitting in a
into
room by
perspective.
yourself. Yeah, studying.
Yes, like all of the family weddings that I missed and all of the parties I didn't go to and
Yes.
all of the friends' big occasions that I didn't get to see. At the very least, when you look at the per
Impact.
the impact and how have you ever done like the per wear cost for a dress that you're going to buy of like, okay, if I wear this once, I'm going to pay $200 for it. If I'm going to wear it 10 times, it's only like
I try not to
20.
think about those things when it comes to fashion.
But it's something like when you think about, okay, when I think about the per hour agony that I went through, now it's way the hell lower
It
because we can reach so many people.
is
Well,
very.
and there's just some funny stories. Like I was thinking back because we've done this now for about 4.5 years, and I was thinking about one time I saw a new patient and I was talking to her and I talked about everything and I made some recommendations to her and she just broke out and started laughing. And I'm like, I'm sorry, did I say something funny? And she goes, I listened to your podcast. And she goes, I told my husband that this is what you're going to talk about and this is what you're going to recommend. And you did exactly that. And I'm
I have
like, that's just so funny.
I have patients who do that too. They're like, "Can you tell us what you think about this? I'm pretty sure I know what you're already going to say, but just in case."
Well, and we really set out to do this so we could really talk to people about things that are really true and things that are really current. Instead of, it's just hard to look on the internet, really, if you're in any area and really know what you're getting is truthful information. And so,
Mhm.
all those old tests that hang out on the internet never die. One of the reasons we did this is so that people really know kind of what they really need to do to help get pregnant. And so we hope we've helped a lot of people along the way.
That's pretty fantastic. So let's dive into this week's topic, which is sperm. Go swimmers. So we're gonna do a question episode on male factor questions. And so let's dive in. What do you got, Susan?
Okay. So our first one is about sperm collecting for testing in IVF. My husband, who's in his early 40s, never masturbates due to his religion, and we are apart for long times due to his work. So we aren't together enough to keep his sperm fresh. We got special condoms from our clinic to use at home for collection, but now we can make sure it's at the best sample for his testing and for freezing for IVF when we are apart for so long. The next time he's here will be 2 months apart. He has never used condoms and is extra large width. So our first attempt didn't work when I tried to assist with putting it on. So we had to cancel his appointment. I'm worried about him being able to produce a sample on a schedule for an appointment, even with the condom option.
That's hard.
That's a
Oh my
tough
God, I didn't mean
question.
to say that.
It is uncensored, Carrie, so you're okay there.
I mean, that's fair. But oh, that's really hard. We just had a patient in clinic recently where it was an IVF cycle. We were doing an egg retrieval and he was just not able to get a sample on command, which is not that unusual. I mean,
Yeah.
that happens periodically. And so we freeze eggs, so we always are set and ready to go. But I really feel for the couples who are going through that because it's such a difficult thing to say, okay, do this right now. Ready, set, go.
Yeah, I would say this is a great example. As long as his sperm isn't really, really, really poor. I mean, it sounds like you're going to IVF, but it doesn't sound like we're dealing with only like 10 sperm. This is a great example of a time to collect. So, I mean, obviously he'll need to do an ejaculate before to kind of clear out the system. And then maybe a few days later, have an appointment for you to collect and bring in sperm to be cryopreserved. We all like fresh sperm for IVF, but I mean, we get lots of people pregnant using frozen sperm. And what I found is taking away the pressure of the IVF part, even though it's still pressure, you have an appointment, it's not the same as we have an egg retrieval this morning and we need to collect at 4 a.m. And oh, by the way, you have stimulated ovaries, which I mean, collecting with intercourse with hyperstimulated ovaries the day of retrieval, that's not going to be fun for you for sure. And so I think preemptive collection and freezing is probably a good option to consider.
So just a side note too, and we haven't done this, I haven't done this recently, but every now and then when guys have trouble collecting, we used a combo of Valium and Viagra. So talk to your doctor about that. The two of those together can actually work quite well. The only caveat, and this is actually really serious, if your husband is on nitro-paste or nitroglycerin, I don't know that they really give that much anymore, but there can be an interaction, a really fatal interaction. So if there's any cardiac issues, generally that's not a great idea. But if your husband's young and healthy otherwise, a combo of Valium and Viagra really does a good job of helping guys collect that normally would have trouble.
The person driving his sample in that scenario.
Yeah.
Absolutely.
Yeah.
All right. Let's do our next one. My husband and I found out we have male factor infertility earlier this year. We have been trying for 2.5 years. We recently found out that he has a Y chromosome deletion AZFB. We have been so sad to find out because it usually means that we can't have biological kids. We were told that his urologist that specializes in fertility possibly knew more about further mapping of the Y chromosome to help guide a decision about doing a microdeletion. I have been looking into more information about this. I feel so sad about the whole thing and would like to find hope seeing this urologist. Do you know of this new information about Y chromosome deletion, AZFB, and finding sperm using microdeletion?
Oh, that is such a tough diagnosis.
Why don't we back up a little bit and talk a little bit about the different AZFs? There's A, B, and C. And generally speaking, you're not going to find sperm with A or B. And sometimes we can find sperm with C, has been the general rule in the past.
Well, and I think too, it's one of those things where, again, we're all gynecologists, but I think a lot of times I know with our urology, and I would go to a urology doctor who's subspecialized in infertility. A lot of times they'll kind of look and sometimes if they think there's any hope that there's sperm there, they'll actually do aspirations either from the epididymis or from the testes. And so sometimes just doing a blood test, and you didn't mention, I don't think if a blood test has been done yet, just to see kind of what your, what his hormones say, sometimes that can be helpful, but certainly an exam can be helpful. And every now and then you know, I mean, in medicine, you can never say never. I mean, there's certain guidelines that we have, but it's definitely worth seeing the urologist and make sure you see one who subspecializes in infertility, because this is really where they excel, as opposed to just a general urologist who takes care of, you know, kidneys and ureters and all that kind of stuff. You need to see somebody like that. And sometimes they'll even just try. I mean, I've even had patients where in certain situations, they really didn't think there was anything there, but they would even go in and take a little piece of the testes and sometimes can find some sperm. So that's one of those things. Unfortunately, nobody can probably really tell you until that's done, whether or not there's going to be sperm there or not.
And even with AZFB, I mean, kind of classically, the information we're always told is that there's 100% absence of sperm in patients with AZF-A and B microdeletions, but AZFC can have some. Well, there have since been enough publications out there where you can find sperm in AZFB. I mean, the percentages are low, like we're talking like 7%.
Not zero.
But it's not zero. And in this case, the difference is huge. And so you definitely need to find somebody who's had extra training, the male reproductive urology folks. So they do their several years of urology training, and then they do some additional focusing completely on sperm retrieval. And the other medications that may be helpful there. The other thing that you may want to do is consider it, and part of this is going to be based on what your cycles are. Like I've got a couple that I'm doing this with right now where she makes pretty decent number of eggs. We are going to go through with multiple egg retrievals, get all of her eggs and freeze them, because he's going to have to go through a microtessie. And the urologist that he's working with is like, we're going to get probably one attempt to do this, because if I have to do this again, that means I got to go in that much deeper, and it's going to be that much longer. And so we want to do this once and once only. So we are getting far more eggs than we would otherwise get in this young and healthy woman, so that we have enough to work with, to have plenty of backup, so that when he goes through this procedure, after she's done with all of her eggs, we've got enough eggs so we can just keep our fingers crossed that we at least get something.
So I'm going to go off on a little bit of a tangent about when we're talking about fellowship trained urologists for fertility. If you're calling around to find out about a urologist, I wouldn't just say, hey, does this doctor work with infertility patients?
Yeah,
I would
definitely
say,
not.
has this doctor done additional training after residency to specialize in fertility? Because I think that's the only, because I don't think it's the same as when we do reproductive endocrinology fellowships. So they don't have the same type of certification, but being that specific, I think, is going to help you get the person that we're looking for. Now, realize that those types of urologists are few and far in between. I mean,
they're like unicorns, actually.
They are.
Yes.
I mean, in the entire state of Texas, I'm going to estimate we have less than 10 of them. Okay. And one of the most famous one of them has been in Houston. So the fact that there are less than 10 and we have one of the most famous, it's kind of crazy. So it's just one of those things that you have to be very specific about. And so,
well, and there's a group too, and not that we're trying to plug them, but Posterity Health, you can look them up and see who their urologists are. There may be one other group too that I can't think of right now. Can you guys think of? But they have trained, you know, subspecialty trained urologists. State of Tennessee, there's only 3 or 4 that I know of in the state. So they're really far and far between. They're probably in bigger cities, most likely.
yeah.
In Nevada, there are 0 specialty trained.
Really?
And so we actually partner with Posterity, and we're bringing them into our clinic in order to get that care for men in this state, because it otherwise does not exist. And it's actually it's super helpful. Like I love having them as a resource, because it means that they can take all that training and apply it to patients who need it the most. And so and then, you know, I also send to Southern California and Arizona and all the other specialty training institutions where they have these guys. But it's a hard find to get these guys.
And there's a handful of other urologists who still do a lot of it. You just want somebody who has a lot of experience. And some of them have a lot of experience just from doing a lot of it in their practice. I know we have one gentleman like that in Austin that we work with quite a bit. And so it's just, you want somebody who doesn't tinker in fertility, somebody who has actually a full dedication
Mhm.
Yeah,
to
exactly.
fertility. So,
Somebody who can do like advanced micro-testes.
mhm.
That's what you're really looking for because they need the surgical microscope and they need the skill set. And neither of those are just taught in basic urology residencies most of the time.
Yeah. All right. Ready for our next one?
Let's do it.
Hi, I'm 35 years old. Husband's 34. We've been trying for 3 years. We had one miscarriage this last summer. After trying for 6 more months, they had no luck. Sought guidance from a fertility clinic. With my testing, I found out I have a blood clotting mutation, PAI1. So even if I get pregnant, I'll need to take Lovenox. My AMH is 1.3. Husband gave a semen analysis and for the next plan of action, and he had no sperm. How did this happen? I was pregnant months ago. We were referred to a urologist, and I still feel at loss for answers. We can't really afford IVF, but it seems that that's our option. I'm at a loss in what happened with my AMH. How fast do we need to act?
So he has no sperm, she said. So they got pregnant and then
Had a
he just
miscarriage.
and he collected and he had no sperm.
Correct.
So the good news potentially about that is it may be fixable. And one of the things that we see, and we've talked about this a lot on the podcast, is sort of the best male birth control is testosterone. And the first thing that I think of when a guy just shows up out of the blue with no sperm is I go, hey, are you taking these supplements from the internet? Have you been to the low T clinic recently? A lot of men, some men need testosterone, but even if your husband is in that category, so say he's taking testosterone, you don't know about it, or say he didn't realize that's a problem, then sometimes if you see a urologist, like we were talking about, who's subspecialty trained, he can switch your husband over to medicine like Clomid. And, that's typically, we think of that as being a medicine that women are on, but Clomid helps men produce the hormones that they need from their brain, the luteinizing hormone and FSH. And it goes down and it stimulates the testes to produce testosterone, which will make him feel good, and also sperm. Whereas if he gets testosterone, it interrupts that circle. So that circuit is you produce FSH and LH from the brain, both men and women. In men, it's sort of a separate system. FSH makes sperm produce, LH makes you produce testosterone, and it feeds back to the brain. And so if the brain gets a signal that has plenty of testosterone, then that whole circuit shuts down. And so, my first thought would be ask him what he's taken. If he's taken testosterone, that's your answer. The good news is generally if you stop testosterone, particularly if he's not been taking it for a while, usually he'll return to whatever his baseline is in about 3 months, because it takes about 3 months for sperm to be produced. And so that would be my first thought. And then he probably needs to have hormones checked if he's not on testosterone, to see kind of where in the circuit the problem's happening and why he's not producing sperm.
On that note, even some of those workout supplements that have like pre-testosterone, I've seen sperm wiped out from
Yes.
those. Okay.
Yeah.
Also, if he has been ill recently, if he had a high fever, we've seen that wipe out sperm. Okay. And I mean, those are kind of the big things that we think about transient loss of sperm, and realize it only takes one good one. Okay. So, I mean, the good thing is you have gotten pregnant. We know that he has the ability to create sperm. And so, one, get a second semen analysis. No one ever makes any major decisions based on a single semen analysis. So get another one. We'll probably need some hormone levels, maybe some genetics. Looking at, we just talked about that Y chromosome microdeletion, and also just his general karyotype, how many chromosomes he has. Those things can often shed some light on what can be done. But there's lots of guys who come into our clinics with low sperm counts, and we're able to help them achieve pregnancy. Some of them we can do it without IVF, but there's a lot of them that have to. And on your AMH is still within the normal range,
Yeah.
especially for your age. And so, you have, I wouldn't be like, oh no, in 6 months to a year, I'm not going to have any eggs. Okay. Now we never know what everybody's trajectory is going to be, but it's unlikely in that time frame you're going to be in the no-go zone.
The other thing to consider with this is, where was that semen analysis done? Because not all semen analyses are created equal. For example, for the most part, I use the major lab companies to do ours because that's where patients have insurance coverage and I want them to get it paid for. But when I have a semen analysis where it really matters because we're coming down to very specific numbers, I have them collect in the lab that's attached to us with Ovation, because they're like, their andrologists do this day in, day out, every day, all day, and this is their career. And so they're really good at finding sperm where an automated machine wouldn't. And so that's another thing to think about as well, is maybe when you get that second semen analysis, consider where you're having it done, because your fertility clinic is going to know local to them where the best one is, and it's probably going to be in their office, because they're going to have people who really do this all day, every day, and have a very vested interest in paying attention to some of the details, and they can help give you a little bit better idea of what's going on.
One other thing I happened to think about was health conditions. And generally, for a 34-year-old guy, and generally you would think he's pretty healthy, but some men that have long-standing diabetes can also have a condition called retrograde ejaculation. And that's where basically, and I'm not really sure of the mechanism, but when you've had long-standing diabetes, when a guy ejaculates, the sperm actually goes backwards into the bladder. And so sometimes guys will kind of notice that, gosh, the volume of the ejaculate's a lot different now, a lot lower. The other thing that they'll often notice, if this is the case, is when they urinate after that, that it looks kind of cloudy, and that's because there's a lot of sperm in there. The good news about that is, if we can figure that out, there is a way to treat them with some medicine so that we can actually use that sperm and potentially do insemination. So kind of a long shot, but every now and then, we do see guys that have that, and that can be the cause for no sperm.
I would say diabetes is the one we see it the most commonly, but I think any man with any type of neurological dysfunction, because it's a neurological dysfunction that's happening, that could be applicable. So that's a great one. All right, our next one. My husband and I have been trying to conceive for 18 months. She's 30, husband's 31, never had a positive pregnancy test. She's had normal evaluation, TSH 4.33, which I would say is kind of
that's a little
actually elevated. AMH 1.79, currently on 5th round of letrozole and low dose of Synthroid using OPKs. Husband's results, count 53 million per mil, motility 70%, morphology 1%. He's also diagnosed with a grade 3 varicocele in his left testicle and hydrocele on the right. Urologist is sending him for DNA fragmentation test, as he's unsure about performing surgery due to his high count and motility. What do you think about best interventions from here? More tests, IUI, IVF. We're currently waiting on consultation to join a program. Thank you.
So that question is a great demonstration of what your personal values and priorities are, because what you value is really going to play a part in what you do and when. So we have some patients who value information above all else. They want to know exactly why this is happening, why it's not working, why they want absolute data on everything. And for those patients, yep, you do the DNA fragmentation, you get into a subspecialist male urology, reproductive urologist, and you go for that information. We have other patients where the priority is, we just want to try the simplest thing first, whether it's due to moral, ethical, religious, financial, whatever, whatever the underlying guiding value is, they want to do simplest first. In that case, you just start with the simplest. You try IUIs and see how they go and go from there. There are other patients where they want to conceive using their own genetics as the absolute priority as soon as possible. Those are the patients who go straight to IVF. The other information is a little less, it's not that it's less useful, it's just it won't necessarily make the big overarching changes. And so in that case, you don't spend your time and your money on all the diagnostic information. You just go straight to IVF, where they can handpick, do ICSI on the best looking sperm, where that 1% morphology no longer is particularly important, and they can fight around the varicocele and the hydrocele and things like that. There are other patients where, and this doesn't apply to you guys specifically because that sperm count in the 50 millions is fine, but there are some patients where they have very, very, very low absent sperm counts. And the question there is, is using your own DNA the priority, where you have to go through IVF and advanced procedures, or is just getting pregnant where using a sperm donor makes more sense? So all of this is based on the underlying priorities of the patient. And so people always ask, well, what would you do? And I'm that annoying doctor who turns around and says, well, what's your priority? Because if this, then this, if that, then that. Because once you identify the priority, the plan pretty much writes itself. It's just, you got to tell us what's important to you, and then we'll act accordingly.
The other thing to consider is, like Carrie said, if you would be a fan of IVF, this wouldn't be applicable. But if you were thinking about, well, gosh, we really would like to do the least expensive, least involved treatment, do like IUI, then that's where the sperm QT test can be helpful. It'll kind of, because he has a good count, but the morphology's off. And so we used to make a bigger deal about morphology, I think, than we do now. I mean, certainly if it's 1%, that's low, but we really don't know for sure if that really makes a big difference or not, because we used to have this sperm penetration test, which we no longer do anymore. And so really the thing that's taken the place of that is the sperm QT test. And it really gives us information about how the sperm functions. So the numbers, we used to think if he's got a good number of sperm and it can move and it can get to the egg, we don't know really about the morphology, but good chance you guys can get pregnant. Now we know that there are some men who have a really good sperm count, volume, motility, everything looks beautiful, but it doesn't do anything. It doesn't get into the egg and bind to and penetrate it. That's important if you're going to do IUI. If you're going to do IVF, it doesn't matter. So go straight to IVF. There's no reason to do the sperm QT test because it's not applicable to us actually taking the sperm and putting it inside the egg.
So a couple of things I'd like to comment about. So first of all, morphology is probably the least important of all the parameters of everything we've talked about. In fact, probably about every 10 years, there's a discussion on whether or not we should even include morphology in the semen analysis. And so it's something that I kind of encourage people not to get too hung up on. It's like, yes, we need to pay attention to it. When you're talking about DNA fragmentation, I tend to do a lot of DNA fragmentation testing. Now, if you have DNA fragmentation there's generally two ways to deal with it. One, and kind of urologists tend to, I think, go on this side. They're like, oh, well, we need to go do a sperm aspiration, which if you do a sperm aspiration, then your only option is IVF. There is another option nowadays called Zymot. It's essentially a little maze that we put the sperm through, and the sperm that comes out the other side theoretically have a lower degree of DNA fragmentation. And so that we have the ability, if you have high enough sperm counts, to do with IUI. I am a huge fan of the sperm QT. So we do have a whole episode about sperm QT, but in general, what sperm QT does is it looks at genes within the sperm that can get abnormally turned on or off through your lifetime from various environmental, health, etc. exposures. And if those genes, a lot of them are turned off, the sperm don't know how to bind to, penetrate, and actually fertilize the egg. So if those are high, then in most cases, you're probably going to need IVF, because there's a part of IVF called ICSI, intracytoplasmic sperm injection, where we inject the best looking sperm into each egg. That bypasses the genes, and then the sperm knows what to do from there. So kind of, as we've said, a lot of it depends on what your goals are and if you want to have all the pieces of information. All right. Good stuff. Okay. My husband and I are about to start our first and only IVF cycle. My brother passed away last year, and my family is giving us his life insurance money to pay for IVF. The pressure is high. I just turned 38, PCOS, AMH 13.2. Woohoo!
That's great.
AFC averages around 18. Husband has very low motility and morphology, but improved motility to 40%, morphology to 4%, equal to 2.5 million motile sperm post-wash. My question is, his reproductive urologist, who's the best in the state, refuses to do a DNA fragmentation test because they said it doesn't change the protocol and it adds anxiety. But I feel anxious not having that information. Would you agree if this is our only shot? Would DNA fragmentation information change your approach? Thank you.
I mean, if you're going to, so she said she's doing IVF, right?
IVF one time.
Yes. So, I mean, you can certainly do DNA fragmentation, but the problem is when they take that sperm and they figure that out, what the DNA fragmentation is, it's not going to change clinically what the doctor's going to do or what the embryologist is going to do. You
I
guys are looking at
disagree
your
with
phone.
that.
You do?
Yeah, if we have positive
With
DNA
ICSI?
fragmentation, they can either, urologist can go do a biopsy to get the sperm, or they can put the ejaculate through the Zymot device. So I disagree that it wouldn't change the course of events in IVF.
But would Zymot really change that much?
I mean,
I don't use Zymot. I haven't seen data that says Zymot would change that. But if you want to know, you can easily do that. I mean, you can easily, I mean, you can go onto a website and actually you can send your sperm off. You don't have to go through a reproductive urologist. So if you really want to do that, you can. I guess my point was, if we're doing IVF, they're going to pick the most beautiful sperm, the sperm that moves, and put it inside the egg. And so in my lab, it wouldn't change anything. Maybe in Susan's lab it would, but not in mine.
yeah. What about you, Carrie?
I think some of it is looking at the functional components of it in terms of, and I don't, correct me if I'm wrong, I didn't hear anything about varicocele, hydrocele, or any sort of structural abnormalities. There was also no comment on behavioral things. And so things like marijuana, tobacco use, or any nicotine use, weight, obesity, health, alcohol, all of those exposures, not to mention any occupational exposures that may have, any health conditions that need to be optimized. Like those are the other things that I think would make an impact, because if money is tight, which when is money not tight, really? Then it may make more sense to address some of those straight up. And those can be really hard sells to people, like saying, hey, no alcohol for the next 3 to 6 months, no other substances, eat healthy, all of those things. Like those are major things. And people, they're not only addictions that happen, but there's behavioral components that drive a lot of those things too, where you're actually treating underlying anxiety, depression, whatever it may be, with those habits rather than with other medication. And so I think some of it is looking holistically, like, okay, what are the things that you probably don't really need a doctor to tell you that you should fix? And think about those as well. I very rarely say no to getting additional information, because I'm a data whore and I love more information. I think some of the things may or may not make a difference. It just, a lot of that depends on the underlying lab that you have. Because if it will make a difference in that lab, then absolutely get it. If it's not going to make a difference, he's got a point of, don't pay money for a test that's not going to change what you do. So talk with your reproductive endocrinologist as well to see if they're able to do anything different. Because if they are versus aren't, that may really shape what you do. Also, if you're going to have so much anxiety over not getting the test, just get the stupid test. Like this is not worth it. There is no risk to this test in terms of doing it, besides however much money you're going to spend to pay for it. And so if it's causing this much anxiety, just get it.
Do it.
Yeah, and one thing I would say that we would all agree on, with your AMH at 13.2, that's fabulous. So at 38, the good news is you're going to get a good number of eggs. And so, I would say it's kind of like buying a lottery ticket. If if your AMH were really low, you might get 2 lottery tickets to win the Powerball. If it's 13.2, you're going to get 15 or 20 lottery tickets to play the Powerball. So I do think that your AMH will be really helpful, and just give your embryologist, your fertility doctor, more embryos hopefully to choose from if we're lucky.
All right, good deal. Y'all want to do one more?
Let's do one more.
Okay.
Sure.
My husband has done 2 semen analyses and had a low volume of 1.2 milliliters after 4 days of abstaining. His morphology is 6%, motility 53%, and concentration 161 million. Woohoo! After 9 months of unexplained infertility, I'm wondering if the volume has any effect on our chances. All of the other tests have come back normal. The doctor said volume isn't an issue, but what do you think? Should we only be having intercourse once or twice during the fertile window to make sure we have enough volume? Is there anything else we can do to increase his volume? Thanks. 1.2 mil.
1.2, is that his volume?
Yeah. So this is one of those things where you have to look at the whole picture. because when we're factoring in total motile counts of sperm, it's all the numbers that make a difference. So for example, I just had a patient who had like, I don't know, 20 million sperm. Like it just hit the normal count, but his volume was so high that it ultimately didn't matter. This is the opposite of that, where his sperm count is so high that you could have half a mil, and we don't necessarily care about that because the ultimate total motile count of sperm, so in this case 160 million times 53%, that's still high enough. And so I wouldn't worry about that. The other thing you got to consider is when guys are collecting sperm samples in the
Stressful
office
environment.
for this intent, it is different than what you may experience while you are actually having sex, where he is actually actively engaged and willing to do this. Volumes tend to be higher in that instance, because collecting in a small dark room is very different than collecting with your significant other.
And aiming your cup.
And what?
Aiming for a cup.
Yes, and aiming for a cup, because that's
true. And that's why the volume can be low too.
And that's why the volume can be low too, because missing the cup happens way more than anybody
time.
admits to. Yeah.
Yeah.
So I don't think I would lose a lot of sleep over this.
And I would say, actually, in our lab, I'm pretty sure 1.2 milliliters is actually within normal ranges at this point in time due to classifications. So I don't think that there are volume issues. I think you would probably be a great candidate for a sperm QT test to make sure there's nothing going on.
Yeah, other issues potentially.
You know, when we've had a lot of people with quote unexplained infertility, and over the last couple of years, this test has helped explain some of those. So, you know, unexplained infertility is a really hard thing to kind of comprehend. But also it sounds like, so, you know, we're doing, let me see. So you've been doing like timed intercourse. And I guess you've been doing maybe some letrozole or Clomid with it. For unexplained infertility, you know, the two treatments that are actually recommended are ovulation induction with insemination or IVF. So in people who are normally ovulatory, just doing oral medications tends not to work. And so, you know, that's something to kind of think about and kicking things up a notch, even if you end up not doing additional testing.
Yeah, and just one thing I was going to add in too. I mean, now that we're getting in the hotter part of the season, sometimes just being dehydrated, he may just need to drink more water. That's something else that might help a little bit. Simple, but not be worthwhile to try.
Agreed. All right.
All right.
This is a very productive episode in going through all of these male questions. It's kind of nice.
And we hope reproductive and productive, right?
Reproductive and productive. Absolutely. So to our audience, thank you so much for listening. We are very, very appreciative that you helped us hit this 1 million point in downloads and number of listeners. Be sure to tune in next week for more. Subscribe. Leave us a review on Apple Podcasts or Spotify. We'd love to hear from you. We're on Instagram, Facebook, and YouTube. So hop on by, leave us a like, hello, and tell us what you're thinking.
You can also visit us on fertilitydocs.uncensored.com to submit questions just like we answered today. And just like today, all questions will be answered anonymously for our Ask the Docs segment or for segments like this. We'd love to hear from you. These are great questions. Thanks.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon.
Bye. Bye.